I would now invite Garima Gupta, who is a community consultant at the National Health Systems Resource Center, New Delhi. Her major work areas include research and program management. She was involved in evaluation of ASHA and Janani Suraksha Yojana schemes in 8 states. Over to Garima.
Good afternoon, everyone. I'll be presenting the findings of Janani Suraksha Yojana evaluation, which was conducted in 8 high-focus states. I would be filling in for Dr. Rajani, who was supposed to be here and presented, but due to some personal reasons, she could not make it. As we all know, JSY was launched in 2005 and is a flagship scheme of NRHM. It has differential payment norms across states. That is, there are different criteria for incentives and payment amounts in high focus and non-high focus states, and among them in rural and high and urban areas. In the first year of launch, JSY became an instant hit by registering about 2 lakh beneficiaries, which increased to about 1 crore in the year 2010 when the study was conducted. The initial conditions of age to be over 19 years and a parity to be up to 2 was removed following the Supreme Court orders, which led to a provision of rupees 500 to BPL women in case of home delivery and rupees 1000 to 1400 for women who opted for institutional deliveries. The study used a mixed method approach by using both quantitative and qualitative methods to look at the context, mechanism and outcomes of the program deriving from the realistic evaluation methodology. 3 districts were selected in each state, each of the EAG states, based on the criteria of high performing, poor performing and tribal population. The quantitative survey was conducted in 12 districts, and 2,759 women with institutional deliveries and 710 women with home deliveries were interviewed. I'll be able to present only key findings because of the limitation of the time. So if we look at the 23,000 women who were line listed across 360 villages in 12 districts, about 54% of these women went for institutional deliveries. The mix of the choice of facility was 48% went to public institutions and 6% went to private sector. There's a clear increase in excess of women from poor and SC/ST categories. As you'll see from this graph, about 43% of the women who opted for institutional deliveries were from SC/ST background. This was found to be highest in the district of Nabrangpur with 76% and in Bastar with 62%. On the other hand, it was lowest in the district of Dumka with 19%. In case of women choosing for institutional deliveries from poor economic background, about 50% of the women were classified as from BPL families. This was highest in Madhepur with 75%, and in other states it was over 35%. There was a clear increase in trends for institutional deliveries. To look at this increase, we asked women who opted for institutional delivery in their recent pregnancy and had a parity of more than 1. That is, they had more than 1 deliveries. So of these women, 51% said that their previous delivery was conducted at home. And interestingly, this is the gap between 2 years, where the last previous delivery and the current delivery was between the 2 years of a gap. The highest trend increase was seen in Kaushambi with 77%, followed by Nabrangpur and Madhepura. However, the lowest figures come from Angul and Morena with 23 to 26%. If we look at the increase in caseload of institutional deliveries, we see that despite of adding multiple facilities in the NRHM during the NRHM period and opening up of the existing facilities for the women to access institutional deliveries, we find that only few facilities at the block level and above are catering to these services. So if we look at 5,830 institutions which we studied in 21 districts, only 15% were providing delivery care services. 3 patterns of provision of delivery services emerged across states. For example, in UP and Bihar, only 2 to 3 PHCs were providing delivery services, that to a very small number, followed by CHCs and district hospitals. While in Rajasthan and MP, 50 to 70% of the PHCs were providing delivery services, but again, this was a low volume figure, followed by CHCs and district hospital. In the remaining 4 states, the delivery services was provided by mainly CHCs and DH, with only sporadic cases of delivery numbers coming from PHCs. In terms of access for emergency care, we find in our evaluation that one FRU was available for the population of 5 lakh. On an average, there were about 2 to 3 FRUs in every district. But in terms of numbers and contribution from public sector, out of the 101 institutions providing C-section services, 37 were from public sector and 64 from private sector. Mission hospitals emerged to be a major player in some districts, and they are catering to significant proportion of the EMOC services and acting up as a backup for the public health facilities. However, in terms of new facility-based newborn care, SNCUs were available only in 11 facilities out of 23 districts. Again, 7 were in public sector and 4 were in private sector. In terms of management of complications, if we compare this figure against with the proportion of deliveries happening in the private sector, we note that about 13% of the women who went for institutional deliveries opted for private sector. However, in case of management of complications, 55% of those women went to private sector. So about 570 women with maternal complications were interviewed and 477 had sought treatment. Of this, 55%, the first resort of care was sought at public health institution, while the final place of treatment turned out to be a private sector. So there was an increase of a shift of about 10% women from public institution to the private sector. But in case of hospitalization, cases requiring hospitalization for a small number of women, about 250, private sector was catering to 53%, while public health institution was catering to 47%. This also explains the high out-of-pocket expenditure in these cases, which was about 3,431 rupees on an average, and turns out to be 3 times the out-of-pocket expenditure which is incurred in institutional care. But if we look at the preparedness of the health facility, are we geared to cater to a large number of women coming to our doorsteps? Shortage of human resource, as Jim Lee just explained, was the central problem. About 13 districts had a nurse-doctor ratio of less than 1, while it was between 1 to 1.6 in 5 of the districts, turning out to be highest only in Kaushambi with 2.5. Poor availability of essential drugs and equipments were reported even at the district hospital levels. Only in district hospital of Dehradun were all the essential equipments available, while all the essential drugs were available only in 2 of the studied 12 districts. Poor status of availability of electricity, water supply, and clean toilets was a big problem. In terms of vehicle used by these women to reach the institutions, we find that 53% were still relying on hired private vehicles. Only 13% used free transport provided by services. Here I would like to highlight the Nabrangpur case, where 70% of the women who came for institutional delivery used the Janani Express vehicle, which was an innovative model with the mini Janani Express vehicles being stationed at PHCs and Janani Express vehicles being stationed at CSCs and district hospital, with the rationale that a vehicle should be available within the time period of 30 minutes. However, the major problem here seems to be there was no facility available for the drop back. So about 28% of these women who hired a vehicle kept the vehicle waiting in the institution and chose to return by it because of practical reasons of unavailability of vehicles and high costs incurred by them. This was seen in 43% cases in Garhwa, Bastar and Morena, while it was 11% in Kaushambi. If we look at the quality of care provided by these institutions, we find that misuse of oxytocin was found in districts like Dehradun, Nalanda, Bageshwar, Bharatpur and Nabrangpur, while irrational use of antibiotics and IV line was seen across the board. Institutional deliveries inside the institutions were reported even to be conducted by DICE in 38% of the cases in Kaushambi, while in 13 to 80% of the cases in Morena and Madhepura. As we mentioned earlier, there were about 43% of the women who had home deliveries during our line listing, but about 10% of these women were not JSY beneficiaries, owing to the criteria that were imposed on them they should be BPL, from a BPL family, they should be over 19 years of age, should have a parity of up to 2, and in some cases should have a live birth. This excludes a lot of women who are at the risk of developing maternal complications and probably in maternal death. The highest difference was seen in the districts of Garhwal, Dumka and Nabrangpur, which ranged from 40% to 53% women being left out because of these conditionalities. The reasons for home deliveries, as we all know, is the common reasons which we are aware of, like unavailability of transport, high cost of transport, family perceptions of not willing, faith in the die, no need because no complication, and no information about benefits. Demand side objective problems, like there was no one to accompany and they found home was more comfortable from the experiences they would have heard from their friends at the public institutions. In terms of JSY payments, the incentive payments were better in case of institutional deliveries, as 86% of the beneficiaries got the payment, in contrast to 14% in home deliveries. If you look at the out-of-pocket expenditures, women having home deliveries also reported out-of-pocket expenditures as reported by 54%, and the average cost comes out to be 586 rupees. In case of institutional deliveries, 82 reported out-of-pocket expenditure with an average cost coming out to be 1,028 rupees, and it further increases to 1,400 to 1,600 if the cost of referral transport where they are hiring a vehicle is also factored in. If you look at the breakup of this out-of-pocket expenditure, as it was being discussed in the morning, most of it goes to the buying of drugs, surgery charges, or in the IPD charges, diagnostics, and paying fees to the provider, and which was reported by about 16%, while informal payments to class 4 employees were reported by 2%. However, if we look at the reasons for institutional delivery, we find that women are making rational choices, and it is not always driven with the JSY incentive, as 76% of the women went to institution because they thought it was a safer option. 32% thought that the institution has become more accessible, while money provided under JSY was also reported by 51%, but this seems to be a spin-off effect by the percentage of Nabrangpur, where 93% women said that JSY incentive was a reason, and it correlates with the high expenditure they incurred at the facility. With the backdrop of universal health coverage, a policy shift was seen from conditional cash transfers to entitlements, and the findings of the study were used by the policy makers to implement the Janani Suraksha Yojana, Suraksha कार्यक्रम, which entitles every pregnant woman and newborn for free healthcare services, referral transport, pick and drop, very important, diet during hospitalization, drugs and diagnostics. While recently Empowered Program Committee has put up a proposal for approval to remove all the conditionalities for pregnant women, whether they go for institutional deliveries or home deliveries, for the JSY incentive, and a uniform incentive of 600 to be given to all ASHAs. However, now coming to the next steps, what should be our next steps to increase this access? We all know that JSY has led to an increase in institutional deliveries, but we need to take caution and expend the human resources by developing retention and recruitment strategies, scaling up the multi-scaling programs, increasing the facilities, providing the facility-based newborn care as well as EMOC care, use of printed protocols for care so that quality of care is not compromised, reporting formats for recording complications, and a responsive resource allocation based on the caseload some facilities take up and the equity of access. Thank you. Sorry.
Thank you. Thank you, Garima.